Acute STEMI, early diagnosis, consists of history taking, physical examination, finding symptoms compatible with myocardial ischemia, but in some cases, it may not come directly with chest tightness, such as tired breathing, nausea, vomiting, fatigue, palpitations, syncope, etc., together with ECG abnormalities that can indicate STEMI, including there was STE in 2 adjacent leads, with the criteria being J-point elevation of V2, V3 greater than 2 mm in men greater than 40 years, greater than 2.5 mm in men, 1.5 mm in women, STE greater than 1 mm in other leads. In inferior MI, V3R, V4R is recommended to determine RV infraction. If an isolated STD is present at V1, V3 greater than 0.5 mm, especially with T-wave positive, posterior MI is suspected. STE greater than 0.5 mm on V7, V9 is suspected. A bundle branch block is often difficult to diagnose, so if ongoing MI is suspected, treat it as STEMI patients. Ventricular pacing is often difficult to diagnose, using the same considerations as the BB-Babov, which may require urgent angiography or a reprogramming pacemaker to look at intrinsic heart rhythm. Left main coronary obstruction preceded by STD greater than 1 mm in greater than 6 surface leads with STI of R, V1. In some patients with suspected acute occlusion of coronary artery and having ongoing MI but without STE on ECG, e.g., very early, occluded circumflex coronary artery, acute occlusion of vein graft or left main disease. In the case of nitroglycerin, then the symptoms completely disappeared and the ECG returned to normal. To determine the cause of coronary spasm, early coronary angiography is recommended within 24 hours. In some situations where the diagnosis is uncertain, echocardiography is recommended. To assist in the initial diagnosis if this is not possible, recommend a primary PCI strategy. Minimum goal: FMC to ECG plus diagnosis lesser than 10 nauseae. Select primary PCI greater than fibrinolysis if time delay lesser than 120 minutes. STEMI diagnosis to wire crossing lesser than 60 minutes. STEMI diagnosis to wire crossing lesser than 90 minutes. STEMI diagnosis to fibrinolysis lesser than 10 minutes. Fibrinolysis to efficacy evaluation 6 to -90 minutes. Fibrinolysis to angiography 2-24 hours. Treatment: choose a treatment plan between primary PCI or fibrinolysis. If the diagnosis is made in a hospital that performs PCI, it is advisable to choose the primary PCI strategy. If the diagnosis is made outside the hospital or in the hospital where PCI is not possible, estimate the time of STEMI diagnosis to wire crossing. If lesser than 120 minutes, use the primary PCI strategy. If greater than 120 minutes, select the fibrinolysis strategy. Onset greater than 12 hours with ongoing MI, CHF, shock, mechanical complication, malignant arrhythmias, primary PCI. Symptomatic treatment: ECG monitoring, O2 supplement only in cases where O2 sat lesser than 90%, titrated IV opioid to reduce pain, mild tranquilizer in patients with extreme anxiety. Nitrate is not recommended for routine use in the acute phase, but IV nitrate may be useful in patients with hypertension or heart failure if contraindicated. Hypotension, RV infraction, phosphodiesterase type 5 inhibitors 48. Primary PCI strategy: antiplatelet therapies, DAPT, aspirin 1 to 300 mg PO plus P2Y12 inhibitor, ticagrelor or prasugrel. Ticagrelor 180 mg PO loading, then 90 mg PO Biidor. Prasugrel 60 mg PO loading, then 10 mg divided by D. Contraindicated if history of stroke, TIA, not recommended in patients greater than 75 years of age or in persons weighing lesser than 60 kg. Clopidogrel 600 mg PO loading, then 75 mg divided by D, or cangrelor in patients who cannot be given as oral agents. Anticoagulant therapies: enoxaparin 0.5 mg per kilogram IV Boluser. Bivarudin 0.75 mg per kilogram IV bolus, then 1.75 mg per kilogram divided by HX up to 4 hours post-procedure, or UFH 70-100 IU, KGIV bolus 50-70 IU divided by KGIV bolus GPIB, III inhibitors. Fibrinolysis strategy: antiplatelet co-therapy, aspirin 1 to 300 mg PO plus clopidogrel 300 mg PO loading, then 75 mg divided by D. Anticoagulant co-therapy greater than 48 hours suggests enoxaparin. Enoxaparin lesser than 75 years 30 mg IV bolus weight 15 min Hg FR lesser than 30 ml. Myoni 0.73 meters 2 OD dose long until revascularization or DC. Enoxaparin greater than 75 years IV bolus 0.75 mg per kilogram SCQ12H, for example FR lesser than 30 ml. Myoni 0.73 meters 2 odd dose, or UFH 60 IU, KGIV bolus followed by 12 IU, kg, HX 24 48 hours FTT ratio 1.52 or FTT 50 to 70 seconds. Fondaparin X 2.5 mg IV bolus, then 2.5 mg SC odds up to 8. Fibrinolytic therapy recommends tenecteplase. Tenecteplase dose IV bolus 30 mg, 35 mg, 40 mg, 45 mg, 50 mg over 5 seconds and decreased 50% reduction in size in people greater than 75 years. Alteplase 15 mg IV bolus, then 0.75 mg per kilogram over 30 minutes, then 0.5 mg per kilogram over 60 minutes. Riteplase 10 units IV over 2 minutes, then 10 UIV bolus 30 minutes later. Streptokinase 1.5 million units IV over 30 to 60 minutes. Rescue PCIF after fibrinolysis, since segment resolution lesser than 50% at 6 to -90 minutes after fibrinolytic therapy, hemodynamic or electrical instability, worsening ischemia, or persistent chest pain. In patients with reperfusion following fibrinolysis, chest pain resolved elevation resolution greater than 50% at 90 minutes after fibrinolytic therapy, reperfusion arrhythmia 2H after. Treatment refer top CI2 24 hours after fibrinolysis. Post-cardiac arrest. Urgent angiography is recommended within 2 hours for patients with STEMI-compatible ECG or suspected ongoing MI such as chest pain prior to arrest. CAD history. In cases where the ECG does not have STE, it is recommended to look for other causes along with urgent echocardiography. In cases with less chance of neurological recovery, e.g., unwitnessed cardiac arrest, no BLS greater than 10 minutes, initial non-shockable rhythm, ACLS greater than 20 minutes, consider non-invasive coronary strategy. AX complication. Dysrhythmias, sinus tachycardia, IF, SVT unstable cardioversion, ongoing ischemia stable versus atenolol 2 to 5 mg IV greater than 2 minutes, metoprolol 2 to 5 mg IV Q 2 to 5 minutes total 15 meters. MG, B blocker digoxin 0 to 0.5 mg IV Q4H, sinus bradycardia, CHB pacing unresponsive symptomatic bradycardia, Mobitz 2 higher AV block, new LBBB, bifascicular blocks, overdrive pacing. INVT, recurrent sinus pause greater than 3 seconds. Heart failure, watch HF. Mechanical complication, surgical TX. Pericarditis, assess 650 mg po Q forminus 6H or colchicine 0.6 mg po bid. RV infraction, maintenance per load hypotension NSS 1 to 2 liters to butamine, avoid diuretic. And nitrate, if LV dysfunction is present, reduce afterload by administering nitroprusside or IABP. Recurrent, refractory ischemia, IABP if emergency catheterization is not possible. Thank you for watching. Please like and subscribe for new videos.